My name is Tamsin Rose, and I have the great pleasure of being your moderator this morning. Welcome to everyone who's joining us. For those of you who use social media, please use the hashtag ECCAM 2022. That's ECCAM 2022, and we'll put it in the chat for everyone, and that's so that you can contribute to the conversation that we're hoping to be launched for next month, because March is the European Colorectal Cancer Awareness Month, and throughout our session this morning we're going to be hopefully inspiring you and giving you information and ideas about how you can take part and make March a really exciting month for everyone. So now let me pass the floor to Zorana Maravic from Digestive Cancers Europe, the director there. Zorana, please tell us about March and Colorectal Cancer Awareness Month.
Thank you, Tamsin. Thank you for the introduction, and also thank you for being with us today at another DICE event dedicated to colorectal cancer. In front of DICE, I would like to welcome all of you in the audience to our ECCAM 2022 launch meeting. I see a lot of familiar names in the audience, as well as those that I know only virtually, and I hope that next year we will be able to hold a live meeting and we will be able to see you all face to face. So ECCAM, or European Colorectal Cancer Awareness Month, for us at Digestive Cancers Europe, I believe that I can safely say, but also for our member organizations, is the most important awareness moment during the year. It started in 2008 when Yola Gorbut, co-founder of DICE, established March as the European Colorectal Cancer Awareness Month. And since that time, we did a lot of events in the European Parliament, always trying to improve colorectal cancer awareness, but even more the awareness on the importance of early colorectal cancer diagnosis, as well as advocating for colorectal cancer screening to become equally available to all Europeans in the screening age, which is currently 50 to 74 years. And I will repeat what probably everybody in this webinars knows, but we should keep repeating it until we see formal population screening programs running across Europe with high participation rates. If diagnosed at stage 1, colorectal cancer can be treated in 90%, or I want to say that 90% of patients would be alive 5 years after their diagnosis. Once diagnosed at stage 4, the overall survival is only 10%. The data that was available before COVID, and I don't know whether we have more recent data, shows that 1/4 of patients is still diagnosed at the metastatic stage. And we need to do better. And when it comes to the treatment costs, it's 10 times more expensive to treat patients in stage 4 than to treat patients in stage 1, not to mention their quality of life for those that are undergoing treatment. But the great news, and it's good that we have a great news, that in some countries, they have managed to diagnose almost 50% of their colorectal cancer patients in stage 1. And we should aim to achieve this. Obviously, this is not something that we can do overnight, but we should learn from good performing countries, step by step, implement good screening practices, collect the relevant data from screening programs, measure the total health economic value, evaluate the programs regularly, and further improve them until we succeed. We are hopeful that with many initiatives of the Beating Cancer Plan, with the endorsement of the final report of the BICA committee that happened last week, and expecting the update of the screening recommendations that will happen later this year, every day we are one step closer to seeing less people suffer from colorectal cancer in Europe. On the other hand, we recognize now that today, 2 years since the COVID started, the situation for colorectal cancer patients is worse. I know that experts are very cautious in providing us with figures, but we believe that there is a large number of undiagnosed colorectal cancer cases because of screening programs being stopped and not being able to catch up. because of non-existing screening programs in some countries, because citizens were not able to see their GPs when they had symptoms, or they were afraid not to get COVID, and that was the reason they didn't visit their GPs. Therefore, we felt that we should do something about it, and our campaign in March focuses on raising awareness on colorectal cancer symptoms, ways to prevent the disease, as well as the importance of screening. And I'm proud to say that the campaign will simultaneously be rolled out in 14 European languages. And I would like to take the opportunity to thank our member organizations for their great support in running this campaign. And please support the campaign, like, follow, and share it on social media. As Tamzin said, for this event and for the duration of March, please use the hashtag ECCAM 2022. At the end of the meeting, Katie Young, our communication manager, who did an excellent job with the campaign, will present it to you. And later you will also hear from patients, advocates, experts, and policymakers on what was the impact of pandemic on colorectal cancer patients, on patient advocates, patient organizations, screening programs, as well as about the importance of awareness raising campaigns. And you will hear also some success stories. Finally, at the end, you will hear about the next steps from the European and national policymakers. Please feel free to ask your questions and write them down in the Q&A box. And welcome once again to the meeting. Tamzin, over to you.
Thank you very much, Zorana. And that I know that the whole team at the Digestive Cancers Europe have worked really hard to make sure that there's lots of activities and things that people can be involved in March to be part of this Colorectal Cancer Awareness Month. Let me now bring in our next speaker. That's Vincent de Jong from the Stichting Darmkanker in the Netherlands. He is a patient advocate and champion who's going to be sharing some perspective. So let me just ask you, Vincent, what was the role of your organization during the COVID-19 pandemic, which we're still hopefully coming out of, but still very much here? And can you share with us some of the experiences and learnings that you found in your organization when trying to deal with this situation?
Well, first, in the first few months of COVID, that screening program was shut down. So that was also, really sad to see that in the first year of COVID, the number of diagnoses had dropped with close to 10% due to the screening program, but also, like Zorana said, people afraid going to a general practitioner because they said, well, yeah, I perhaps don't have colon cancer, but I could get COVID, which was very reasonable thinking. So, but that said, for our organization, yes, we say, we try to educate the public, just go to the office where you have bleeding, pain, whatever. Because the risk outweigh the benefit of being diagnosed at an early stage. So next to this, 3 times a year, where we used to organize a seminar for the public, so for Dutch colon cancer patients and their caretakers in our country. But yes, COVID made that impossible, so we turned it into webinars. So we had to adapt to that situation as organization. From a personal level, well, I'm a stage 4 patient survivor. I was diagnosed in 2015, but I'm in permanent remission since 2 surgeries and 6 months of chemotherapy. But so I didn't fear Corona, not that much myself, but I know lots of people that are really scared for not receiving therapy, not going to appointments. I know one family with teenage children that stayed in their home for 2 years. Only the children were allowed to go to school, but groceries were delivered at the door. The one of the adults is a cancer patient, and she lived on their 2nd floor for 2 years out of fear. That's truly sad story. So, but it's the way it is. There's an unknown virus, unknown complications, and very sad.
Luke, can you give us just a little bit more context? What might be the learnings that you would take from this? Because I hear the word fear, it came through very clearly. So there was on the one hand, the services shut down, and on the other hand, there was such fear that when services were available, people didn't access them. What would be the lesson that you think we should take from this? Vincent?
Well, education and putting things into perspective.
Okay.
And nowadays, with people, most patients to take 2 vaccinations and a booster, or even three vaccinations, and Omicron is not that bad, not a risk for most patients at this moment, unless you're doing therapy, chemotherapy, and your immune system is depleted. But
okay, so this issue of putting things into perspective and making sure there's education, but also information out there. And I think that's probably where there's a huge role for patient organizations and cancer foundations like yourselves to get the message out there. And I think that's also why next month, the Colorectal Cancer Awareness Month, is a real opportunity to create platforms and engage people, to be able to give them hope and optimism and understanding that there are services out there, there are things that can be done, and that they should feel confident in accessing care. Thank you very much, Vincent. Let me now introduce Carlo Senore, who's our next speaker, who is going to be sharing with us again a little bit more about the impact of COVID-19 on colorectal cancer screening programs across Europe. And Carlo is the coordinator for the screening program in the region of Piedmont in Italy. So Carlo, let me ask you, do we know the impact of COVID-19 on the colorectal cancer programs across Europe? We heard from Vincent that in the beginning things got shut down. There was a tremendous reluctance and fear of people to engage. We've all seen the headlines about hospitals overwhelmed. So what can you tell us about the real situation?
Yeah, thank you. That's well, in fact, as we know, most programs stopped their activity in March 2020 during the first wave of the pandemic. And screening was generally started between May and July, but the impact of the disruption has been longer, as programs were often not able to restart at full capacity. The volume of procedure is still lower in many cases than in the pre-COVID period as a result of the adoption of infection control measures. So a part of the population will and is still experiencing a longer delay than the duration of the disruption. In Italy, for example, the average delay was still about 5 months by the end of May 2021, even if some programs said be able to recover completely. We are starting to have some preliminary data about the impact of COVID-19 pandemic on colorectal cancer screening activity in 2020. From the survey that has been designed and conducted by the International Cancer Screening Network, Colorectal Cancer Screening Intergroup, aimed to collect aggregated quantitative data about screening activity and outcomes. The preliminary results from the activity of 11 programs from 8 European countries are showing a decrease in colorectal cancer screening activity in 2020 as compared to 2019, which was ranging between 16 and 49%. We can then expect that a similar proportion of colorectal cancer, which have been detected as screening in those programs, will have a diagnosis delayed up to 6 months. In some cases, also the participation rate in primary screening and the compliance with colonoscopy referral among subjects with positive FIT result was reduced. And also, as subjects from lower socioeconomic status were more likely to experience diagnostic delay, screening disruption may potentially widen health disparities. Which are the potential health impact of these delays? And well, we have some data from validated simulation modeling, in particular the Cancer Global Modeling Consortium, simulated different scenarios of disruption and recovery strategies to predict both long-term outcomes and short-term and long-term costs. And the modeling results are suggesting that screening interruption might increase the number of late-stage cancer, the number of deaths, and it might have a higher impact on the older age groups. The impact is also related to the duration of disruption and to the participation during recovery period, which you have seen was often reduced, as also Vincent was suggesting. And most of the estimated relative excess in colorectal mortality attributed to screening disruption can be expected during the next 5 to 10 years. And we have preliminary reports from UK and Spain, referring to the year 2020, which are indicating that there has been also a stage shift of screen-detected cancer with an increase in more advanced stage and compared to stage 1 cancer. But modeling results are also suggesting that we can mitigate the impact of disruption by implementing recovery strategies. Well, performing a complete catch-up of missed screen examination while maintaining a regular screen services requires additional colonoscopy capacity, which might not be available. But we can clear the screening backlog using limited colonoscopy resources by slightly increasing the FIT positivity threshold for an ongoing program, for example, over the next 24 months. And this strategy could already prevent up to 60% of the excess cancer death related to the disruption. Other possible ways to handle a backlog in screening include extending intervals, adopting risk-based approaches to screening. But of course, there are also problems in implementing this kind of strategies. Setting priority for invitation, adopting risk-based strategies, especially within established organized population-based program, requires careful consideration of the local context. Many programs may just not be able to implement the changes of this nature. The IT system and the organizational infrastructure of the program may require significant modification and development to adapt to the evolving scenarios of activity. And then we need data. Timely and comprehensive data about the impact of these changes are needed to inform decision-making about recovery strategies, resource management, impact and harm mitigation. And this requires monitoring to support program quality and equity. And implementing these changes might be facilitated having an explicit and transparent communication of uncertainties and explaining the rationale for the adoption of specific recovery strategies. And these should be important to involve also patient and citizen organization to be able to achieve these goals in mitigating the impact of disruption. Thank you.
Thank you. Let me now sort of reflect on something you said, because I think you raised some really interesting points, which is there was in the first wave, everything shut down. Then things opened up again, and now we have this sort of hybrid where we've got prioritization. And you've indicated, okay, there's now there's a backlog in screening. And do we prioritize certain risk groups? Do we, extend the different timeframes to do it? You propose different ways, but as you say, none of them are easy to implement because they require changes that might be temporary to your whole screening system, your data system. So that's quite a lot of work. Do you think that our systems are ready for it? Because already in many countries, screening is something that there are gaps and they're missing. Is it worth trying to fiddle around with a screening system to try and fix the gap of the last 2 years? Or is it better as an overall goal, particularly in countries where we know screening is not meeting the targets, to just keep pushing at the screening as it is, rather than try and change it to address this 2-year blip on the program where people didn't get diagnosed?
Well, as you say, in fact, implementing changes is always difficult, and it's more difficult when the program was not yet well established, were not covering the entire population, and they had less established infrastructure, because you need an organizational and IT infrastructure to run a proper program and a high quality program. But well, in fact, the reason for aiming to implement strategies to achieve a wider coverage of the population and to try to recover a bit of the backlog was mainly related to the issues I mentioned about equity. The concern about this disruption in screening is that the more deprived groups had less resources to have access to preventive services. Other people might, with more resources, might also had some preventive examination in the private sector, for example. So the impact of the disruption was mitigated. But for the rest of the population, this might not be the case. So in the public health sector, the aim should be to ensure everyone a coverage for this service. And so the only way probably to achieve this is to establish some priorities in the invitation. There are people who are at lower risk, whose interval can be extended without a major risk, but there are other groups which might need to be addressed before. And for example, older age group might have a worse health impact when you are delaying screening. So priority when they're starting should be invite, for example, older age group. And this can be relatively easily implemented if you have an information system where you can have the information about age so that you can just prioritize your invitation. It's not so easy, but starting this approach will also be a good, let's say, will favor in the future the adoption of measures which also for those programs who are not covering yet the entire population to have a stronger and more resilient systems to offer the screening to everyone.
Thank you, Carlo. And just as a reminder to everyone who's joined the webinar, you can submit your questions that we'll be picking up at the end in our using the Q&A function at the bottom. I noticed that a couple of our panelists have already started to share links in the chat to different data sources that they're going to be referring to. So that's a resource that you can already access. Vincent, before we move on to the next panel, I'd like you to perhaps give us some suggestions. How do we overcome hesitancy and how do we build trust again in the population where we've had such levels of fear? You mentioned earlier, you know, education is part of it, but really when there are people who are concerned that we still know that where are COVID patients now? They're in the hospital. So, and we want people to come back to hospitals. So what can we do to create this trust? And Carlo's mentioned that, you know, this strong socioeconomic impact here. So the people who are most at risk are also the people least likely to engage with screening programs. These are the people who we really have to reach out to and bring them in and build trust. Do you have any suggestions about how your organization is doing that?
Well, it's a very tough question because participation rate in screening in Holland is over 70%, but yeah, the 29% that are not coming in are the people you're referring to, the certain neighborhoods, areas, people of certain degree of education, and they're at this moment without COVID, they are also hard to find and hard to motivate. So yeah, the only thing I could imagine is repeating the message. But however, in the local situation in Holland, what will help us tremendously is that a very popular comedian and a very popular DJ were diagnosed stage 3 last year, and they were very open about it. The DJ even made a documentary about this process, so filming of the surgery, his consults with his surgeon, etc. So, and he will, next month he will play an important role in our media campaign on ECCAM. So and the guy is popular in all ages, all regions, all areas of Holland. So he's our access ticket to those groups that are
excellent.
hard to target.
Vincent, you've raised a really important point, which is that the messenger is important. It's we need active patients, and also clinicians are good at speaking in public to get out and engage. And you know, people having spokespeople or champions or patient advocates who are relatable to the different audiences is absolutely key. And I think again, it's making it very underlines the importance next month of the Colorectal Awareness Month, is that we can get as many people engaged, because we need to access different parts of the population, even the more unusual people who are not usually speaking on health issues. We need to bring them into the conversation. So thank you to Zorana and to Vincent and to Carlo for that first section where we were looking at the impact of COVID-19 on screening processes.